is now my pleasure to welcome our third speaker, Dr. Sujatha Sunil. Dr. Sunil is a group leader of the Vector Borne Diseases Group at the International Center for Genetic Engineering and Biotechnology. Dr. Sunil, take it away.
Good morning, one and all. I'm Dr. Sujatha Sunil, group leader of the Vector Borne Diseases Group at the International Center for Genetic Engineering and Biotechnology, New Delhi. And today I'm going to talk about the infectious disease epidemiology in the current times and try to bring in concepts of what is the relevance of the growing infectious disease in the present communicable diseases that are also existing. So as way of definition, health, disease, and medicines. So health in its broader sense can be defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Whereas disease is defined as a pathological process that is a deviation from the biological norm. And medicine is the science or practice of the diagnosis, treatment, and prevention of disease. Health transition is defined as the shifts that take place in the patterns of disease and causes of death. And the health transitions can be put up as two parts. One is the demographic transition that involves the population dynamics, and the epidemiological transition that describes the disease pattern of a population during the demographic transition. So when we talk about epidemiological transition stages, especially in developing countries, ranging from the early 20th century to the present times, the early 20th century and prior to that was burdened with a set of factors that played a major role in disease dynamics. They were communicable diseases, which could be pandemics, which could be endemic. Reproductive morbidity was high, mortality was also high. Nutritional deficiency was prevalent, coupled with poor sanitation and housing, poor personal hygiene, high child mortality, high disability adjusted life years, as we call as DALY, was the contributing factors for death and the health statistics in the early 20th century. And most of them were preventable disease burden. Then during the 1940s and till the 1970s, there was a rapid change, basically in the mid-20th century, which was witnessed by a recession of epidemics, which led to the later intervention or the later transition, which had its own set of burden, which we call as the triple health burden, which comprised of an unfinished old set of communicable diseases, reproductive morbidity, nutritional deficiency, rapid population growth, and there was also a rising new set of cardiovascular diseases, malignancies, diabetes, stress, aging and diseases of the elderly, accidents, emerging and resurgent diseases, which was also coupled with lagging healthcare because the health system and the medical training were ill-suited for the rising chronic diseases. There was also continuing acute diseases that needed immediate attention. And there was a defined need for long-term care for the geriatrics, the disabled, and the mentally ill. While these transition stages had an impact on the life expectancy, as we see, so the first transition stage had a life expectancy of about 30 years, which progressed to about 45 years. And now we have a life expectancy as much as 70 years plus. So these eras in epidemiology could actually be differentiated into three eras that was defined by the predominating or the dominating issues at that era, which was called as the miasma, that where you had poor sanitation statistics, which was a greater part of the 19th century, and which was followed by the germ theory, which was mostly the infectious disease epidemiology, which most of my talk in the later parts will be concentrating on, which comprised of the 19th century through the first half of the 20th century, and what we currently call as the black box or the chronic disease epidemiology, which was in the later half of the 20th century. So if you're going to talk about how these were connected with one another, we speak about the age of the pestilence and the famine, which was the poor use of ecological resource or lack of social and economical capital, and which led to the next part of the age of the receding pandemics, which was a product of increased economic growth, increased use of ecological resources, which finally led to the age of the chronic disease, that is the improved medical care and social determinants that influenced health. But what was important in each of these eras was there was no specific distinction from one fall or rise of a specific era, and each of them was a dynamic process over time. So if you're going to talk about the whole world healthcare status, the global status, we find there are several countries that follow certain categories which encompasses all these kinds of eras as simultaneously. For instance, the developed countries have a specific set of, belong to the category 1, where they have highly developed healthcare infrastructures, where simultaneously there are the category 5 countries with the least developed healthcare infrastructures. And these are directly correlating to, if you're going to study the statistics, we are directly correlating to the rise of infectious disease epidemiology versus your chronic disease epidemiology, or definitely it is a combination of both these in epidemiology that plays a major role. So when we come to the current challenges in combating infectious diseases, at least as of the early 2000s, what we did see was there was a decrease in the incidence of infectious diseases. At the same time, there was an increase in the non-communicable diseases. And if you are going to talk about the different kind of non-communicable diseases, we could even say that it was categorized, or it could be clustered entirely around trauma or diabetes or coronary heart diseases or cancer. So what happens, and what was the reason in the challenges with combating infectious diseases in the background of these non-communicable diseases? It was that more pathogens were identified than the drugs that were being developed. 1 death in 3 of the 54 million deaths worldwide is from an infectious cause. What started off as a boon or a wonder drug against infectious diseases, that is the antibiotics, also turned out to be a huge villain as they turned into become antibiotic resistant and became leading to superbugs. Increased human travel also attributed to a great level to the challenge that in combating infectious diseases that we have an ongoing example as we speak now. And advancement in modern medical practices, such as development in invasive technologies, also had their own difficulties in increasing the amount or the number of infectious diseases that were being deduced or that were being detected. This is an slide that depicts the re-emergence of the infectious diseases in the 21st century, And you can see that they comprises of broadly two types. We are talking of re-emerging or resurging infectious diseases that are coming up almost all across the continents over the globe. And at the same time, we are also seeing newly emerging, unheard of, unknown of infections which were previously not known of. I'm not even going into the thing of the deliberately emerging diseases that will come up as way of biowarfare that we keep hearing about. And if you're going to take a subset of these infectious diseases, for instance, when we talk about the pandemics since the 1918, since we are talking in an age of pandemic right now, we see that several of these pandemics are coming at the beginning of the 21st century. They have contributed a lot to the way the infectious biology epidemiology has been studied. If you're going to look into the arboviral diseases in the 21st century, the three main things we immediately look upon are the dengue, chikungunya, and Zika. And what we do see is that most of them, this is the way that they have progressed since 2010. And we can see that there is a distinct increase in the incidence of these arboviral infections in the 21st century. Even though we do see some of them even up to 2010, this was the existing data because the start of these arboviral infection increase had started way back in the mid-90s or early 2000s. And that has contributed mainly because of travelers, as well as, and that has then resulted in specific diseases. Now, when we go at the case that I would like to bring about to explain the way the epidemiology of infectious diseases, especially arboviral infection, is with respect to studying the work that we have done primarily on epidemiology of chikungunya. So as a brief introduction about what the disease is, chikungunya is an emerging disease of considerable public health importance in India as well as in the global scenario. It occurs in two phases, the acute febrile phase and the chronic arthritic phase. Caused by the chikungunya virus, the infection is generally not life-threatening and has a mortality rate of less than 0.1%. However, it causes high morbidity with a major impact on the daily and is a serious public health concern because there is a huge loss of productive years of an individual that contributes to the country's economy. Currently, there are no vaccines or antiviral treatment available. The disease is symptomatically treated with antipyretics and or with non-steroidal anti-inflammatory drugs, with or without combination to steroids, which has its own potential side effects. So what happened? Why did chikungunya come in the first place? It was there prevalent in the 18th century, in the middle 19th century, even in India. And after the 70s, it completely disappeared from the whole the scenario, the public scenario worldwide. So what happened? What caused the re-emergence of this disease? So the facts are, historically, the mosquito Aedes aegypti was the preferred vector for disease transmission. And the virus is known to exist as three genotypes, mainly the Eastern, Central, and the South African phylogroup over here, and the African phylogroup and the Asian phylogroup. However, in 2005, there was a single point mutation in the envelope protein of one of the genotypes, namely the ECSA genotype, that caused the virus to change its preference of vector transmission. The Aedes albopictus became the preferred vector for transmitting this disease. And this resulted in the main cause of the pandemic, which occurred in 2005, that originated in La Reunion and spread to the rest of the globe. And so if you see the global incidence of chikungunya, when it first struck, this was what was the global incidence of chikungunya in 2006. And this is what is the status as in 2019, where we are only talking about local transmission, and we have not included cases of the imported cases that would definitely increase the amount of incidents that is happening. And what is also important of relevance with respect to chikungunya is, with respect to India, is that India seems to be the hub of chikungunya spread, because it houses both the vectors Aedes aegypti as well as albopictus, and the various waves of transmission that was seen of chikungunya virus in the last 15 years was mainly because of where India contributed to the transmission of the disease. So if you're going to see the status of chikungunya in India, at the time when, after La Reunion, the disease was first detected in Maharashtra in 2005, and quickly it spread to the southern parts of the country. And by 2009, 8 or 9, the whole of the southern part of the country was having huge outbreaks and epidemics of chikungunya. What was noticed was, during all these outbreaks, this outbreak was caused by Aedes aegypti and not albopictus. However, in 2009, the involvement of Aedes albopictus was also witnessed in 2 states in India. But surprisingly, after that, there hasn't been any case reported of albopictus involvement, and all the transmission after that has been only because of Aedes aegypti, because we do not see the mutated form of the virus anywhere in the Indian subcontinent. And as of date, we have as many as 20 states and union territories that have been infected with, that witness chikungunya outbreaks almost every year. And the epidemic, the disease also goes through this pattern of being endemic for several years, and then it reaches an epidemic potential, and then it goes back to being endemic in its occurrence. So we as a group in our research laboratory have been working on the evolution and the divergence of this virus in India, and also try to understand the epidemiology of the virus in the country and those factors that attribute. We have our clinical sites, and the data from these clinical sites is what I'm going to present, and also explain the concept of how the virus might have evolved since its first initial occurrence in 2005. So this was the study pattern where we recruited patients from both these clinical sites, and we subjected the patient's information samples to various kind of analysis, which involves studying the viral load, looking at the neutralization status, correlating the neutralization status and the viral load with disease progression, with the initial acute phase disease progression and the post-acute phase disease progression. And also look into the various kind of phylogenetic analysis, or the various kind of strains that could be circulating in the country at a specific point of time. And what we do see is, what we did find was higher initial viral load during the acute phase of illness had a poor prognosis of the disease. And early seroconversion to neutralizing antibodies had a better prognosis. And different geographical regions had distinct pattern of neutralization depending on the circulating viruses that were there. And the viruses were, of course, phylogenetically different. Next, we wanted to see what was the status of whether the virus was able to coexist with other infection. And since owing to the overlapping clinical infections of dengue, we evaluated the presence of co-infection of chikungunya in the presence of dengue. And what we did see is that there was a very high incidence of co-infection of chikungunya with dengue patients, which also had distinct clinical presentation of these monoinfection and co-infection patterns. And also, there were distinct metabolites in case of monoinfection versus and co-infection versus the co-infected group of patients. So there was a hidden burden of chikungunya in confirmed dengue cases, distinct clinical features that could provide information of co-infection, thereby have a better disease management and patient management protocol, and distinct metabolites regulated in mono and co-infection patients. So next, we wanted to also identify what was the molecular basis of these viruses and these virus strains that were circulating in the country. For this, we established several different kind of molecular tools that involved whole genome sequencing and further identification of molecular signatures, analyzing the samples, looking for recombinants amongst these samples, and correlating with the clinical aspects, clinical information that we have derived from the samples from. What we did see was there was very distinct features over the years. We collected samples, we've been collecting samples from 2010 onwards, and we've been analyzing it in a longitudinal manner over years in different areas. What we do see is that there are constant reintroduction of strains into the country from 2010 onwards, and recombination events are seen in clinical isolates. And we do see that certain mutations are positively selected over the years and between regions. And distinct differences were observed in strains between epidemic and episodic samples. So that brought us to the question, so are there differences when there are epidemics or outbreaks that happen in large scale at different time points? So for this, we analyzed two outbreaks that happened in 2010 and in 2016 in Delhi, and we performed several analysis on them. And what we do see is that these two outbreaks presented with distinct clinical outcomes. And differences in the neutralizing capacity of the binding antibodies had a direct impact on disease progression in the two outbreaks. So when we are going to look at it with respect to its impact on disease presentation, so this was we mapped all the various factors such as the clinical symptoms, the binding antibodies, the serological factors, the neutralizing capacity, the viral load, the visual analog score or the arthritic index of the patient over the disease. And of the two outbreaks, we do see that the disease presentation was different in the two outbreaks, where the 2016, the disease resolved much faster as opposed to the 2016 outbreak patients who were affected by the 2010 outbreak. And this was directly because of the neutralizing capacity of the antibodies, binding antibodies in the early stages, in the very first few days of the disease. And when we looked into the genetic makeup or the genetic determinants of these two outbreaks, we see that there were distinct pathogenic difference in the way the viruses were impacting the disease. And this could be directly attributed to the genetic makeup of the viruses. So from this, what we can conclude is, what we could conclude was, chikungunya is a huge public health concern in India. And the co-infection of chikungunya and dengue is a reality in our country. The comorbidity with chikungunya results in severe disease outcome, And statistics and information such as viral load, neutralizing patterns, and different kind of viruses that are circulating have a direct impact on the disease presentation and disease progression in case of chikungunya virus. And there were also distinct genetic determinants in episodic and epidemic strains were obvious. So what is the relevance of all the work that we had done in chikungunya with respect to the current pandemic? So all these questions that we had asked in the story of chikungunya, they all can be and should be evaluated in case of SARS-CoV-2 also. For instance, this is the global distribution of severe acute respiratory syndrome coronavirus 2, nicknamed as SARS-CoV-2 or originally called as the novel coronavirus 2. And what we do see is the molecular epidemiology is coming up with so many different clades. It's a mishmash of the evolution of virus thanks to modern technologies for evaluating the virus, the generation of so much of the whole genome sequence information. And also what we do see is that there are specific point mutations that could be directly attributed to the infectivity or the infectiveness of the virus in humans. As we see, this is the information we got as of yesterday, I think, that it was seen that there is a specific point mutation that was able to show significantly higher infections with a specific point mutation. So the next part, apart from the virus, is the host response to the virus. What we have seen is COVID-19 seems to be affecting, the host response seems to be an extreme drastic effect, ranging from the impact it can have on the heart, the blood vessels, the kidney, the brain, the lungs, the intestines. And what also we see is that these are having an comorbid or a condition of any of these organs are having a very major negative impact on disease progression. And so the kind of information that we get are being increasing over the time. But what we also see is that comorbidities are playing a very major role in the way the disease is being presented and the way the disease is also getting resolved. And which leads us to more and more questions, like, for instance, how fast is the virus exactly mutating? And what is the exact impact of the host response on virus evolution? And what are the comorbidities and severities of COVID-19? What are the genetic associations that we can come up with respect to the host and the virus? But what is most important and also of major concern is the noise versus signal in the prediction models that are being coming up in the last 6 months, ever since, or the 8 months that we have seen the disease actually since the start of the epidemic. And which raises questions of whether we should change the way we have to evaluate the communicable and the non-communicable disease that we are having right now. So as a final conclusion, what we are seeing is in the existing, the background of the germ theory, the black box, what we are also seeing is that there is an age of the re-emerging pandemics in the backdrop of chronic diseases, non-communicable diseases, that would change the way we look at infectious disease epidemiology. And as the title also says, maybe there is a change in the paradigm of the disease communicable as well as in the non-communicable disease front. So acknowledgements are due to all my collaborators and my funding agencies who have supported our research over the years. And thank you for the time and for the opportunity, Mark. Thank you very much.